Good morning.
Good morning.
It's Dr. Rutledge and Dr. Manchanda. We're here.
I'm really proud to be with the father of mini-gastric bypass, and he has, to his experience, more than 6,000 cases and he is the most experienced person in the world as far as MGB is concerned.
Well, thank you.
And it's a privilege to be with him. And who else can be better than him to explain the technique and tips and tricks of mini-gastric bypass?
Right, so that's what we're here to talk about this morning.
Yeah.
We think the MGB is pretty straightforward, is fair to say, easy operation, but we have seen other surgeons who adopt it, especially if they bring their knowledge from sleeve or Roux-en-Y to the MGB, they can have problems. So the purpose of our discussion today is to go over the tips, traps, techniques of doing MGB.
Yeah.
All right, so good. And you have only experienced with only 1,000 cases.
Yeah. So you are the best person.
1,000 cases in the whole world. How many people?
Yeah, not many.
Yeah, less than a handful maybe.
So considerable experience.
Between the two of us, there's a lot of
Less
brains.
than yours.
Good. All right, so our purpose is we're going to talk about the tips and techniques, the traps, the technique of performing the MGB safely from what we've learned. And we might start off with a brief introduction and say why we do the MGB.
I feel that it is the safest of all the bariatric surgery procedures.
So safety.
Yeah, safety, number one. Takes less than 45 minutes. To complete the surgery.
Simplicity, safety, simplicity, right?
And it is easily reproducible.
Standardized,
Yeah.
right? And efficacy.
Efficacy.
Yeah, in other words, the purpose of the surgery is to get weight loss, and sadly, sleeve, the band, the Roux-en-Y, there are numerous papers saying that the results, the efficacy of those operations are less than ideal. They're good operations, but they're not as effective as we would wish.
Yeah.
But you say in your clinic, you see patients with MGB?
Yeah.
Effective.
And we have found that it can be effective to the tune of 90% of excess weight loss.
So now, are you bragging? But I think that's remarkable to say that when you look at other studies, lap band and sleeve, they're talking about 40 and 50% excess weight loss. And here we reviewed your data, which you have done an excellent job in doing follow-up on. And you were saying, you were nervous because you were finding that your weight loss was close to 100% of excess weight loss. You said, this seems too good.
It's some of the cases almost 100% or more than that.
Right, right. So it's safe, which number one of any treatment, any medical treatment, we want safety.
Yeah. It's strong, very strong.
That's right, so very effective, very powerful, very strong, exactly.
We can alter the dose of the MGB.
Ah, what?
The
What
dose
is this? Alter the dose? What are you talking about?
like we can vary the length of the bypass.
Right, so
And
some
make
patients need a more powerful dose. They need more effective,
Yeah.
more powerful surgery, and others less.
Yeah.
And with a Roux-en-Y, can you adjust it?
I think it's difficult.
No. Most people say Roux-en-Y is a Roux-en-Y is a Roux-en-Y that I know of.
Yeah.
There are other experts in Roux-en-Y, but they say Roux-en-Y is Roux-en-Y. MGB, we have little MGB, and we have big MGB. Right. So
we can vary the dose.
So there are many other advantages. We won't want to talk too much about that, but that is the reason we're thinking about it. That's the reason we advocate it. And we're going to talk about how to do it safely.
And just one more thing.
More?
Yeah.
All right.
Very good result as far as the comorbidities are concerned.
Right. So, resolution of diabetes?
In diabetes, it is wonderful.
Yeah.
I found it wonderful.
Of all the things you can get joy from, to imagine that you can have the potential to have remission of diabetes, a patient who could be protected from blindness from diabetes, heart attack from diabetes, stroke from diabetes, kidney failure from diabetes, or amputation of the legs from diabetes, in a 30 to 60 minute operation. That's why we're talking about MGB today.
Some of the patients were on more than 100 units of insulin.
Yes, Yeah.
And they're often slim.
Yes.
It's really wonderful
Yes.
to see such patients.
Yes.
They're so happy.
And we'd like other surgeons to be able to do it well. We're going to talk about how to do it well.
Yeah.
Because we've seen other surgeons. I just got an email from a surgeon who's a new surgeon in France, and he reports he has a leak at the gastrojejunectomy. So we want to talk about some of the things to avoid the dangerous things, especially because some of the approaches that we use for MGB are different than what is done for sleeve and Roux-en-Y.
Especially we have to guide them that if it is done in the wrong way, they can have problems. Like they can have bioreflux.
Yes.
So to avoid that, which is less than 1 to 2%.
In your series,
Yeah.
how many out of 1,000 had bioreflux?
Because we learned the technique from you. We are following the master. So we are having as low as 1% bioreflux.
Right. So bioreflux in my series is low.
So if done correctly,
Right.
so if it needs to be done correctly.
Right. We're going to talk about that, the short pouch, doing twists, different things like that. So we're going to talk about these things to avoid complications. We're going to go through the details, and to summarize, we're going to talk about the preoperative preparation, the anesthesia and the positioning of the patient, the port placement, the creating the gastric pouch, getting the loop of bowel, adjusting the length of the bowel, doing the gastrojejunectomy, and then maybe if we have a moment or two, some post-op.
Yeah. And also we should also talk about reversibility.
Reversibility. Yeah.
This is the
Why would you want an operation to have revisability or reversibility? Why?
like if the patient loses too much weight
Yeah.
or lands up with some complication,
Absolutely.
right? Then we have to reverse it.
So if you think about it, most other weight loss surgeries do not have to worry about excess weight loss because they're too weak. So in other words, you rarely see patients with a band or a sleeve or Roux-en-Y who've lost too much weight. That's a big success for them, but the reason they have that success, they're not very powerful. MGB is potentially extremely powerful. And so with that great power comes the potential risk that it could be too much for some patients.
Otherwise also I feel that there must be an exit strategy.
Yeah, absolutely.
If there is any deficiency or
Yes,
like in a sleeve, what's the exit strategy?
exactly. So
We must have
the
a-
sleeve is irreversible, and we know this, not to be critical. Every operation has weaknesses, but the sleeve is irreversible, so we know in this city, a patient with liver disease had a sleeve and began to have progressive liver failure,
Yeah.
and there's no reversibility for that. And so he passed away.
Reversibility is important.
And you had a case of liver dysfunction, and you revised the
The
patient,
patient is better.
and the patient got better. But for a few days he got worse,
Yeah.
and then he got better. But that ability to get out of trouble is one more feature.
Yeah.
But we're not going to go through all the features of the good features of the MGB, or we'd be here forever, but we want to talk about the
Technique.
technique. All right, so the preoperative preparation, anything special, preoperative preparation we should tell them about? Do they need to be on a diet?
No,
No.
not specifically.
So a lot of surgeons, put people on a diet.
Yeah, sometimes.
Yeah. But you don't think they need
No,
a diet?
there's no need to.
I agree. What other things do people do? Do they need other special preparation before they come for MGB?
We prefer to give Paglac
Yes.
in patients who have undergone, especially who have undergone previous surgery.
Okay.
We prepare the gut
Okay.
1 day prior to surgery because a few people have undergone cesareans or hysterectomies, so the gut might be adherent.
Okay.
So we prefer to give Paglac in most of our patients.
Okay. And I don't. I used to, when I began 16 years ago, I gave a little bit of a bowel prep, but not anymore. Anything else that we do pre-op? No, I agree. I think activity, healthy diet, not smoking, no NSAIDs, no aspirin. Those things should be, those are kind of standard.
Complete workup, blood workup and cardiac workup.
Right. I think as we would for any general surgery case.
Yeah, and yes,
I think we would say, in general, the risk in our experience of MGB is similar to or less than an average general surgery case.
and in cases who are having psychiatric illnesses, psychiatric evaluation.
Yes. So then we bring the patient to the operating room, and I don't think we'll talk about anesthesia today because that's a long discussion, but there's some special
It's a separate topic.
It's a separate topic, so we might do a paper on anesthesia because we also might be in a little,
Your anesthesia is also very interesting.
very interesting. We have things to say,
Yeah.
but not
Lots of
today.
things.
But patient positioning we'd like to talk about because a lot of people operate between the legs. What do you say?
Yeah, that is patient can have complications.
People don't talk about it, but when you put the patient's legs up and out, you can perineal nerve injury.
Yeah.
And so we operate with the patient supine, with the knees broken with 2 pillows, 3 large straps across the thigh and the upper and lower leg. The arms are both out, and Foley catheter.
Foley catheter if the patient is super obese
Okay.
and especially old age.
Okay. And for my series, we don't use Foley for the past 10 years because the operation is so short, but so use it in some cases.
Some cases.
And again, that's not appropriate for most other kinds of bariatric surgery because they take longer.
Yeah.
Okay, if you have a short operation, most patients and most people, most humans, can hold their urine for 45 minutes.
Yeah.
So it's important then if there is no Foley catheter and the patient has to void on call to the operating and make sure they empty the bladder.
Your anesthesia is also different.
The anesthesia is different.
That's why there's no need for Foley catheter.
That's right. So urinary retention is uncommon because of the specialized anesthetic technique.
Yeah.
What about an arterial line? Everybody gets an arterial line.
No need for a
No arterial line. Central line.
No need for central.
Spinal, to get spinal anesthetic.
No.
No. Okay. So all these
It's
things,
less than 45 minutes surgery.
you don't need.
No need for all this.
But you have an O2 sat monitor.
Yeah.
And the patient is intubated.
Patient is intubated.
Okay. And we talked about the position the patient is supine. And then we take the table and incline it to the maximum of reverse Trendelenburg, as far as the table will go, and maximum left side up.
Yeah.
The surgeon stands on the patient's right side, and the reason for tilting the table is all the tissue comes away.
So you have good exposure of the left upper quadrant.
Right, that's where you're going to operate. And then you want the surgeon standing at ease with the elbows bent at 90 degrees and the wrist in rest position.
And the spleen looking at you.
And the spleen looking at you, but not digging to find the spleen.
Yeah.
And it turns out the robot can only tilt the patient to 10 to 15 degrees. So I watched robot gastric bypass this weekend, and what we saw is that oftentimes a lot of that tissue, especially in the super obese, is laying up against the left hemidiaphragm. So we tilt the patient up, and you have to do that slowly and cautiously to make sure the anesthesiologist doesn't lose the blood pressure. So a lot of attention to detail on that.
Good hydration.
Good hydration, exactly, avoiding dehydration. And carefully tilt the patient up, make sure everything is well. And then we have the tissue move away, and the patient is also in ideal position for the hands to do the surgery.
And a good view of everything. The stomach, the G junction.
Make everything easy for the surgeon.
And the spleen, so we are,
Right.
there's a good view of everything.
Right. And if you lay the patient down flat, if you do that before you tilt, if you look, you'll see everything is washed up in the left upper quadrant. So we tilt them up and you can see it pull away and gives you a place to work. So we like that. Now, what about the other instruments? What instruments are necessary? A lot of technical, specialized instruments to do MGB?
It's all routine instruments.
Nothing. So on the back table, someone says, I want to do MGB. What do we have to have on the back table? What do we need? 3 graspers.
Yeah.
If we're going to close with a stitch, you'll need a needle driver and a pair of scissors. Staple gun.
This is all.
That's it.
And the ports.
Very similar. I mean, it's not much more complex as far as the equipment needs than a gallbladder.
Yeah.
So you've taken an otherwise complex. Do you need a robot?
No.
Bring in the robot for this. It's very simple. And what we're going to talk about, each one of the steps as we go through them, we like to make them easy. We know that there are many technically demanding operations. They're very complex, very difficult, very dangerous steps. What we'd like to do for the good MGB surgeon and the new MGB surgeon, every step should be simple, easy, non-stressful. So the instrumentation is simple.
Yep.
All right. So now, do you want to discuss port placement?
Port placement.
All right. Where do we put the ports?
It's a diamond shaped.
Right.
fashion in which we put the plate ports.
Right.
So can explain the positions.
All right, so the bottom point of the diamond is where the camera goes, and it's not similar to many Roux-en-Y doctors. We don't pay attention to the umbilicus, and I say we make it 1.5 to 2 hand breadths beneath the xiphoesternum in the midline. And you can vary that if you move it up, if you move the ports up, if you move the diamond up cephalad, then you have a better view in dissecting the EG junction, but it's more awkward to do the gastrojejunostomy. So we say about 1.5 to 2 hand breadths below the xiphoesternum. Then we make a working port for the surgeon's left hand beneath the xiphoesternum in the midline, about 2 to 3 finger breadths below the xiphoesternum.
Yeah.
So those are our two in the center. They're the top and bottom of the diamond. And now for the 2 corners of the diamond, on the patient's right side, we're going to put a port between the midclavicular and the anterior axillary line. It should be about 2 or 3 finger breadths below the costal margin, and usually it's going to be about halfway between the 2 midline ports. So that makes the triangle on the left side as you look at the patient's diamond. And on the right-hand side, as you look at the patient, or the patient's left-hand side, on the anterior axillary line, a 5 millimeter port goes there. So now we have kind of a diamond, and then we think of our left hand, the surgeon's left hand, in the upper mid-epigastric port, and we make a mid-clavicular line port, roughly, about a hand breadth and a half between the two, and that is 12, 12, 12, 12, and 1, 5. And the idea there is that the bottom point of the diamond in the midline is the camera port. The top port in the midline is the surgeon's left-hand port. The midclavicular line of the patient's left side is the surgeon's right-hand working port. And if the patient's supine, it's like this, but when we bring the patient up, then the surgeon should be at ease with these 2 hands doing the major portion of the work. The 5 millimeter port is for assistance, and also to hold the loop of bowel at the time we've created the bypass. And then this 12 millimeter port is rarely used, but just for one little movement to move the camera, and sometimes to use for the stapler. So that's the diamond, and maybe we'll show some pictures of this in the paper.
Yep.
Okay, so now we put the ports in. We enter in the usual fashion, maybe a Barry's needle or a Visiport, and we do a brief visual exploration. And then I don't use a liver retractor, but you use a liver retractor. And then we find the crow's foot. Okay, do you want to describe this, what we do? And
we make a section of the crow's foot.
Yeah.
And go along the lesser curvature for a distance of 2 to 5 centimeters. I think more than 5 centimeters.
Yeah, and here I think is maybe the first place where I see Roux-en-Y surgeons tend to make an error, not because they're doing something wrong, but it's opposite of what we would do for MGB. And that is a tendency to take the dissection on the lesser curvature proximal. We recommend that you go distal. We want to make a long pouch, and so if there's a tendency for the Roux-en-Y surgeon to come up from below, staple from below, and have a short gastric pouch, which puts the bile next to the esophagus. And instead we want to say, find the junction between the body and the antrum, and do your dissection distally. So when the staple gun comes in, you have a longer pouch and a longer distance between the esophagus and the gastrojejunostomy.
This is very important. As far as we need to have a long tube so that there is no bioreflux.
Exactly.
This is very important.
There always is going to be bioreflux, but bioreflux where it damages the lining of the tissue happens particularly when bile goes in the esophagus.
Yeah.
Bile can go in the stomach, bile goes in everyone's stomach every day. Routinely we have found there's no problem, but we know from general surgery experience a esophagojejunostomy with a loop never works. It always leads to crippling bioreflux into the lining of the esophagus and very much mucosal damage. So we want to avoid that, and we think that's the reason the old Mason loop failed.
Yep. And we are following the typical Bioreflux 2 procedure.
Exactly.
The long tube.
Yes.
So this is.
And no general surgeon would do a subtotal gastrectomy or total gastrectomy and reconstruct with a Bioreflux tube.
So this is how we are different from Mason's loop.
Absolutely, and many people are confused, and Roux-en-Y surgeons, when they come to the MGB, often don't remember this portion of their general surgery. And we have seen in various conferences people making these very short gastric pouches for MGB, and our bias is this is one of the critical factors we'd like to emphasize in this paper.
So this is very important step.
Yeah, we're going
To go as low as possible.
absolutely. And it's easy to do. It's not complicated. You just need to have the mindset of an MGB surgeon, not of the Roux-en-Y surgeon. Again, it's not a criticism. It's just saying the idea that a Roux-en-Y surgeon has been taught is go higher, go up, go proximal, make it smaller. And the MGB idea is make that long gastric pouch. And it's not complicated. You just have to think about it.
It's typical of modification of the Bioreflux tube.
Exactly the same as if you're doing an antrectomy for a distal gastric cancer or an ulcer. Antrectomy Bioreflux 2, standard general surgery practice. Don't get confused with your Roux-en-Y background and make it into a subtotal gastrectomy type anastomosis, because that doesn't work. You know that as a general surgeon.
Yeah.
We know it from the MGB. We know it from the failure of the Mason loop. Don't make a short pouch.
Right.
Star, asterisk,
Yeah.
emphasis there.
Yeah.
Right. And again, we're sorry about emphasizing it, but we see so many people make that mistake. And it's not a criticism. It's just saying Roux-en-Y and MGB are different.
That's why I wanted to put a lot of emphasis on this.
That's why we're talking about this. The whole paper is just don't make a short pouch.
Yeah.
We have another paper later about the rest of the operation, but this paper just don't make a short pouch.
You're right.
We also recommend take your time. I think you want to skeletonize this area and take away some of the mesentery because it's going to be where you do your anastomosis.
Yeah.
But you don't want to skeletonize it so that you make the tip ischemic. So there's always a balance there. You want the mesentery to bring blood supply, but you want some of it cleaned off, I would say 1, 2, 3 centimeters, because you're going to do your gastrojejunostomy.
At that time, then there's a clear view of the posterior wall.
Yes,
So you can have a fair idea of the posterior and interior wall
absolutely.
and how the anastomosis looks like
Right.
and how good the anastomosis has been made. So you have a fair idea at the end.
Right. Some people say, I just make a tiny hole in the omentum and fire the staple gun. There's nothing wrong with that, but then that leaves that bulky, fatty tissue in the area where you're going to do your gastrojejunostomy, and I think you can be less accurate with the placement of sutures when you have that kind of rolling fat coming over the edge.
You can't be clear whether you are putting the suture in the right place or not.
Right. So we recommend a little bit, maybe 1 centimeter of skeletonization so you can see the serosa of the stomach and the lesser curvature well.
All around.
But not 5 centimeters. Don't take away that blood supply because we need it to bring it into the gastroject. These are little minor things, but again, we have seen people make these little mistakes.
Right.
Good, so we've now begun to skeletonize the lesser curvature. First staple gun, first staple fire. What do you want to comment about this? What are the tricks about the first?
It should be
Fire.
from the epigastric port.
Why?
Just because it should be as below as possible.
Right.
The direction is suitable. It
Exactly.
goes in the direction.
So if you look at our MGB videos, you see the staple gun come in from the top of the screen down. And if you look at a Roux-en-Y video, you often see the staple gun come in from below.
Yeah.
This is not a criticism, but they are making a short pouch. We want to make a long pouch.
Yeah.
So again, we emphasize this because it's different. It's not right or wrong, but
It's
we
difference in technique.
absolutely different in technique. And if we go like this and then you get a bird's beak here, all of a sudden your gastrojejunostomy is up high. So placement of the staple gun is very, very important. Bring it up from that mid-epigastric port down. Right. So it's perpendicular to the lesser curvature.
Particularly lesser curvature.
It's a really minor point, but don't actually divide the stomach.
Yeah.
Do you think anybody could ever do that?
It can be done.
I did it once, but only 1 out of 6,000. This is weird. So, the first staple line is perpendicular to the lesser curvature. That's the bottom of the gastric pouch. The second staple line, I like to bring
At the
in
level of the enter.
at the level of the junction of the body and the antrum. Yeah, and if you go down a little bit onto the antrum, that's okay. Beware a big, thick man who's very thick because it may be so heavy that the blue staple cartridge might not work. And we could also talk about what staple cartridge. You know, you could use a gold cartridge.
At this stage, we should use a green or a gold cartridge.
Okay, to go through the antrum.
Yeah.
Yeah, because it's increased thickness.
Increase thickness.
Right. I have
First two staplers should be green or
gold?
Yeah.
Okay, and so we, in our discussion, our paper, we'll have a few disagreements. I often use a blue here, but I think especially for a thick antrum, you feel it's really thick, then absolutely gold or
It
green.
depends on the thickness of the
Absolutely, yeah.
Otherwise, blue can also be used depending on the thickness of
It also depends where you are. You know, if you're more on the body, then maybe you're okay. Especially if you get down toward the pylorus, it gets very thick, then it's unwise to use a blue.
Right.
And we would never use a white?
No.
Is it, should I say that I know a surgeon who uses white loads for all of the creation? Anyway, so we recommend blue or gold or green. Right. Not white. Although I know someone. All right, and the second firing, I like to bring in from the patient's right-sided port and go a staple there.
Second fire should be from that place.
Yeah, and then the next firing comes from the patient's left mid-clavicular line port,
Yeah.
and we fire repeatedly up to the near the EG junction.
At this stage, I would mention that we will insert a bougie.
Ah, when do you put the bougie in?
After the second stapler, when we have to fire the third stapler, then we can put the bougie.
The combination of the surgeon's left hand, the staple gun or the grasper, and the bougie allows you to begin to create the pouch.
Yeah.
Now, some people, I would say, I have heard occasional, not all, but some sleeve surgeons get very tense about how tight to make the sleeve.
Yeah.
For MGB, we've been making a sleeve for 15 years. Do you need to be very tight against the bougie if you're making an MGB?
I think it should be somewhat away from the bougie. It should not be clinging on the bougie.
I agree. And the reason I think that is if you go very tight against it, you have the potential to pinch and maybe even tear. So I say if you want a smaller gastric pouch, that's fine, but you need a smaller bougie. And trying to get up tight and close to the bougie, I think has a risk, maybe 1 in 100 or maybe 1 in 200 or 300, that as you close that down, you could have a tear.
Yeah. Or there will be tension.
There could be tension there, and that could cause that area of the staple line to be unsafe.
And what size of the bougie should be used?
Well, you use a 36?
32.
32? Okay, so that's big for me. In the United States, I have a 28. But I think that's not critical because obviously you use a larger bougie, but you've had excellent weight loss.
Yeah.
And I think you were bragging earlier, you have 100% excess weight loss or almost 100%.
Yeah, sometimes.
And you don't have a small bougie.
Yeah.
So I think that's, I would agree, and what I would tell the new MGB surgeon, don't be tense about the size of the bougie or the size of the gastric pouch. We believe that creating the gastric pouch is an important part, but whether or not it's 1 or 2 millimeters or 2 centimeters in difference in diameter is not the critical feature of the MGB.
And how long should we take to fire the stapler?
Well, my bias is I used to fire fast as I could, and I've actually done an MGB in 16 minutes without any delay. I think there's good research now, and my own experience is long delays gives a better staple line, it's more secure, and you have better hemostasis.
Half a minute is sufficient?
I think it's different in different patients, but I wait a long time. And especially for a new MGB surgeon until they get their own experience, I can say even take 2 or 3 minutes. Again, if you're going to do 6 staple firings, there are some areas where bleeding is very, very dangerous, and that is particularly at the EG junction and at the closure if you use it on your gastric.
Usually encounter the short gastrics.
Absolutely. So there, if I'm ever going to spend a long time with a great deal of compression, I might use a long time there. But what I would be very much opposed to is people who fire, whether it's short or long time and waiting, and then begin to cauterize or use a harmonic or put clips on the staple line for bleeding. You're opposed to this also.
Yeah.
Yeah, I think that this puts the staple line at risk. It's safe 100 times out of 101, but we have seen, in my experience, sometimes that will decrease the safety of the staple line. And I think...
What do you recommend if the staple line is still bleeding in spite of all these precautions? We should oversew it?
I think so, a figure of 8. Yeah, I think that's the right answer. And Again, I also see some bariatric surgeons who forget their general surgery. If you're going to do a figure of 8 on human tissue, should you take both hands and pull it as tight as possible? I don't think so. I think we were taught that you close it down gently. And so you see these people who are tugging and pulling like they're trying to strangle the tissue. And I think that we know the way that tissue heals is by the blood coming in as the suture begins to lose its purchase on the tissue. So I recommend that we always treat the tissue with a staple gun and the sutures with delicacy, with respect. And so when you put your figure of 8 stitch in and you tie it down, you're not going to lift up and tug up and see this thing, but treat it with respect.
I'm going to the EG junction.
All right, so now again we have something to point out where we are different than many, but not all sleeve surgeons. This is not a criticism of their technique, and not all sleeve surgeons say this, but many sleeve surgeons say it's very important to skeletonize the area of the EG junction, to see one or both crura of the diaphragm, to actually reach up into the crura and pull down any extra stomach that might be there, to identify the hiatal hernia, to repair the crura, and that should be done in every case. Now, that may be, and I don't agree with it, but what we say, we never recommend that for MGB, right?
You should be away from the EG junction.
I agree, and I have had, before I had this experience, I did dissect in the area of the EG junction, and I had 1 or 2 leaks up in that area, and it's a devastating leak.
The blood supply, I would say that the blood supply in this area is very less.
And it's the esophagus.
Yeah.
The esophagus has 2 layers. It's not friendly, and if you happen to put some dissection there, suppose you're using harmonic or another kind of thermal energy, it damages a little bit of the wall. All of a sudden you have a leak, and so that's a devastating area to have a leak, and so we strongly recommend basically avoid it. The argument in the favor of the sleeve surgeons who want to dissect the EG junction is they have to do it to get effective weight loss, and they have to do it to avoid reflux. In the MGB, both of those arguments are not present. In other words, we get superb weight loss. Did you want to take another opportunity to say how good your weight loss is?
Oh.
So we get excellent weight loss. We do not have to take every bit of the fundus there and worry about the fundus. In fact, I think Dr. Kullar thinks if you have a little extra fundus, the patient is actually happier.
Yeah, it makes the patient happier.
They're more comfortable.
Because we have the other component.
Yes.
Helping us.
Exactly. Exactly. Sleeve surgeons, and not everyone says it.
We are not totally dependent on this.
Right.
We have a malabsorptive component as well.
Right. So this is what we want to say again. I think we want to emphasize this, which is a sleeve says we must go to the EG junction. Again, not everyone, but I think Gagne and others say we must attack the EG junction, find both curves. We say that may be necessary for sleeve. It's absolutely not necessary for MGB because we have both components.
Yeah, and this if you make this, if you be away from the EG junction, the patients are happy. They are able to eat, and the patient can eat healthy diet. This is what we want.
And when we went over the list of attractive features of the MGB, one of the attractive features, which we didn't mention, is a happy patient.
Yeah.
In other words, we want to cure the diabetes. We want safety.
Yeah, a patient is eating as well as losing weight. So this is what they want.
Right, exactly. I want to cure my diabetes, but don't make me vomit every day.
Yeah.
Let me have a little bit of healthy food. Let me have a little bit of ice cream if I want.
So going away from the EG junction, we are safe and
Yes.
the patient is happy.
And the patient is happy. So it has the best of both worlds. And again, the reason we emphasize this is there is a whole group of very good surgeons who are attacking the EG junction. And they're publishing papers with 3 and 4% leak rate.
And
Okay?
if you look at the anatomy of if you go to an anatomy book and just see the diagram of the blood supply of the EG junction, it's the minimum.
Right.
So
Exactly.
going near it is, I think it's dangerous.
And we know that because look at the published data from sleeve surgeons. 3, 4%, they say, oh, this is good. Imagine in your practice you had a 3% leak rate. Okay? So you do almost 100 people every 3 months. So that means you'd have a leak every month. And the time that a leak stays in the hospital may be up to 3 months. So could you have a leak in your practice every month and then keep all those people? You'd have to have a sleeve
You
ICU.
cannot continue with this practice.
No, no. So many surgeons don't know this, but you cannot stand a leak, but an EG junction leak is maybe the worst. And again, we strongly recommend that for the MGB, and again, not a criticism of the sleeve, but for the MGB, stay away from the EG junction. All right, now we're done with the first half of the surgery.
First half is done.
Okay, so again, no step was difficult.
Yeah, I think we have covered most of the points.
I think so,
Yeah.
yeah. And I think the emphasis is no technical step in that part of the surgery is difficult.
Yeah.
But it does require maybe changing your mindset if you're a sleeve or Roux-en-Y surgeon newly coming to MGB. Okay, but not difficult, but different. Okay, so now we turn our attention, the camera goes over to the patient's left gutter, retract the omentum medially, and we might take a moment to say we've never, in 6,000 patients that I've done, had to split the omentum. Did you ever have to split the omentum? So now between us, 7,000 patients, never had to split the omentum. We see people doing this all the time because they say it's necessary. Leave the omentum, retract it medially, and there is usually a area between the apron of the omentum and the left gutter. Retract medially, find the ligament of Treitz, and run distally about 2 meters. If you're a new MGB surgeon, I recommend what Dr. Kular did, start a little short of 2 meters. Be cautious. And then as you get more experience, you may want to tailor it for bigger patients, more severe diabetes. You can add to the power of the surgery by adding to the length. But recommend basically 2 meters. And so we should get out and measure with a measuring tape every piece of the bowel?
No.
Why not?
We can have just we can just measure the tip of the grasper,
Yes.
and from that we can get an idea of what's the length of the
Right.
bowel.
And even if we took it out and measured it perfectly, the gut itself changes its length moment to moment based on sympathetic tone, parasympathetic tone, whether the patient has taken in a gaseous soda pop or something like that. So our belief is you cannot be precise. And so attempting to measure it precisely is doomed to failure because the gut changes in length moment to moment. So we recommend that you get an estimate, like you say, look at an instrument. You can put in a piece of umbilical tape or whatever that's measured to get your idea, and then you count that distance, and you want to look at around 2 meters. And when you begin, start a little short of that until you have more experience. All right. Now we take that loop of bowel, put it up in the left gutter, and grasp it in a locking grasper, and then turn our attention away from that. Okay? Now we look at the tip of the gastric pouch, and we make a gastrotomy. I have seen some surgeons make the error of doing the gastrotomy posteriorly, and then that includes the staple line in the anastomosis, and I don't recommend that. So I recommend that the gastrotomy be made anterior, and that we're going to do the gastrojejunostomy with the stapler from the anterior gastrotomy across the staple line. Small point.
Yeah.
So
I think there's a variation of
a variation of how we do
some
that.
people are just cutting the distal part and anastomosis
Yep.
the bowel. Some people are doing a posterior anastomosis because that gives a wonderful lie to the bowel.
Yes,
So I think there's a variation in
that's right, how to do that.
GJ.
Good. So then we will, after our gastrotomy, then we'll turn our attention and look at the small bowel. We'll do an enterotomy. Then we take the camera and move it. Then we put the staple gun in through the camera port. Put the loop of bowel on the staple cartridge. Put the anvil into the stomach, and take a moment to look at the position. You don't want to staple onto the lateral staple line of the stomach, and you want to give space between the lateral staple line and the staple of the gastro-J so there's blood supply.
Yeah, so the sufficient blood supply.
Right. Then carefully fire the staple gun. Make sure that there is a match between the edge of the stomach and the edge of the bowel, and they should both be at exactly the corner, the crotch, the groin of the staple gun.
Right.
If they're different, then you get a bigger defect and it takes more time to close.
So we should be exactly in the middle.
I think so, yeah. Small point, but I think it's worth taking a few moments to get them exactly right. Don't
Otherwise
rush.
you'll have a different length of on the stomach side and on the bowel side,
Yeah.
and we'll
You
have
get-
difficulty in anastomosis.
It just takes more time and you get a big hole and it's, yeah. So And I think if you close the big defect, you have more risk of having a stricture, so.
Yeah.
So then you fire that carefully, wait a good amount of time, make sure there's no bleeding, take that out, and now you close it, and you can close it with hand sewn.
So here also we are different.
Yes.
The anastomosis is wide open.
Anastomosis is wide open,
So we are not creating a small anastomosis.
and Roux-en-Y surgeons say small anastomosis,
So here also the technique is different.
right?
They are, in Roux-en-Y we have to make a small anastomosis, and here we have to make 4.5 centimeter big anastomosis.
Right, right. And again, we're creating restrictions, so our patients eat about 3/4 less than pre-op, but we don't want obstruction. So let me say that again, because I think there's confusion. The lap band, the sleeve, and the Roux-en-Y create restriction through obstruction. They are very similar in my mind to an esophageal stricture. If they eat a block of healthy food and eat a piece of broccoli, it's unpleasant, they vomit, they tell me they're vomiting, they're sick, and they have trouble with that. If they take a big bite of a hard sandwich, again, it sticks at the lap band, it sticks at the small gastric pouch and the narrow outlet of the Roux-en-Y, and they're unhappy. The MGB, we want restriction but no obstruction. We want the patient to be able to eat, and so we make a good wide anastomosis, and so those surgeons coming from the Roux-en-Y often get that.
So in a way this is an anti-reflux procedure.
Absolutely.
It treats GRD.
Absolutely. Absolutely. Very effective. And if you put an obstruction below the gastroesophageal junction, you're actually going to create acid reflux. And that's what we're seeing with the sleeve and the band.
So GRD patients are improving.
Absolutely. What is the frequency? My studies of my patients show that those patients who come in with gastroesophageal reflux disease, GERD, who are taking Prilosec, 85% are improved and off of their Prilosec post-MGB.
We have similar results.
Yeah, so it's good. And once it's closed, we're done.
Yep.
Do we close the ports? Do we close the port sites?
35 minutes. How much time did it take? 35 minutes.
Except when mine bleeds.
It is rare thing.
But I think we've got over all the dangerous points, right?
Yeah.
Take the ports out. How soon can they eat?
We start the patients on oral diet very next day.
And we start them on within a couple of hours. How soon can they walk?
They are walking in the evening.
Walking a few hours later, right? Yeah.
After 2-3 hours they are
Right.
walking.
Have an IV overnight.
And we start the patient on semi-solids on day 2.
Yeah, that's good. That's the case. That's all the details. That's the tricks. That's all we got.
Yeah.
Anything else we left out?
Great. You have explained the things in a very beautiful manner.
Yeah. All right. What do you think? That was good, huh? That was fun.
Great.
I think if they type that up, we could correct it.
Right.
What do you think?
Yeah.
All right. So what do you